So, good morning, everyone. I welcome back every one of you to the second day of our seventh annual Congress of Indian Neurogastroenterology and Motility Association. Organizing chairman being Dr. Anil Arora and organizing secretary being Dr. Shirihari Anikhanti. I believe that you found yesterday's session quite enriching and you had the opportunity to engage with some of the brilliant minds of the field. Today, we are set to delve even deeper into the field to have even better perspective and knowledge in the field. Today, our lineup includes a plenary session, interactive panels, and some thought provoking discussions covering a wide range of topics. I would like my sincere gratitude to all the respected dignitaries, learned doctors, faculty members, and all the participants to be a part of this remarkable journey with us. Thank you, everyone, once again. So, without further ado, let's start with the first session of the day, that is the plenary session. It is a proud to announce that we have received an immense response of around 45 papers, among which 5 best papers have been selected to be presented before the jury member here. And among these 5, 3 will be awarded as the best prize. So now I would like to invite the respected jury members to come on the stage for this session. Dr. V. Jayanti ma'am, Dr. Uday Ghoshal sir, Dr. Anil Arora sir, Dr. Ravindra Mittal sir, and Dr. Ajay Kaul sir. Kindly come up on the stage, sir, to start the session. It is an important announcement that we have strict time guidelines of 7 minutes of presentation and after presentation 3 minutes of discussion. So I request all the participants to kindly follow the time guidelines strictly, abiding by which you will have a positive impact on your assessment. So I would like to invite our first participant, Dr. Uzma Mustafa, to have the presentation on the topic gastric myoelectrical activity based subtyping of patients with functional dyspepsia with and without delayed gastric emptying and gastroparesis.
Good morning, everybody. My work is on gastric myoelectrical activity-based subtyping of patients with gastroparesis and functional dyspepsia with and without delayed gastric emptying. Both gastroparesis and functional dyspepsia are disorders of same spectrum with overlapping symptoms. Delayed gastric emptying is observed in all gastroparesis patients and 1/3 of functional dyspepsia patients. Gastric dysrhythmia in variable loss of interstitial cells of Cahals and abnormal 3 cpm GMA is observed in both the groups, and electrogastrography is said to capture the ICC status of subjects. Our hypothesis was that there may be variability in patients with gastroparesis and functional dyspepsia with normal and delayed gastric emptying in terms of symptom severity, gastric accommodation, and probable difference in their GMA profiles. Our objectives were to evaluate symptom severity, gastric motility, and gastric accommodation and GMA profile with EGG based on water load satiety test. All suspected gastroparesis patients underwent 4-hour solid phase gastric emptying scintigraphy, and mechanical obstruction was ruled out in all of them. Suspected functional dyspepsia were confirmed by ROMFO criteria for FD. Our protocol was approved by Institutional Ethics Committee. And we did solid phase gastric emptying and determined ROMFO criteria for FD for both the group of patients. We determined Abel score and gastroparesis cardinal symptom index for both the groups of patients. EGG was determined for 10 minutes in fasting state, followed by 5 minutes of water load satiety test, and post water load satiety test, there was 30 minutes of GMA recording. And GMA percentage frequency was determined for bradygastria, tachygastria, normogastria, and duodenal respiration. And it was compared with the standard graph to determine GMA class for each patient. We followed the normal EGG process for both the groups of patients. Results, there were 40 patients in gastroparesis and 39 in functional dyspepsia who were comparable in age and gender. Weight loss and diabetes was more significant. Weight loss and diabetes was more significantly pronounced in gastroparesis patients. For gastric emptying, all the patients of gastroparesis exhibited delayed gastric emptying, and 1/3 of functional dyspepsia patients exhibited delayed gastric emptying. room for subtyping for FD, like postprandial distress was common in both the groups, like functional dyspepsia and gastroparesis. Able grade 3, that is gastric failure, was observed in 40% of gastroparesis patients. Short form Napier dyspepsia index, the symptom load was higher in gastroparesis patients, and the associated quality of life was poor in gastroparesis patients. GCSI score was higher in gastroparesis patients, and GCSI subscale scores were also higher in gastroparesis patients. Quality of life was poor in terms of physical health and psychological health in gastroparesis patients, more in gastroparesis patients. And gastroparesis patients also suffered from non-conducive environment. Water load satiety test revealed that about 40% patients of gastroparesis consumed abnormal volumes of water that was less than 238 ml, and water load showed inverse relationship with GCSI score and GCSI subscale scores. Gastric 3 CPM GMA profile, that is hypernormal, normal, hyponormal in fasting state, was comparable in both gastroparesis and functional dyspepsia. Then bradygastria, tachygastria was also comparable in fasting state in both gastroparesis and functional dyspepsia, with and without delayed gastric emptying. Post water load also, the 3 CPM GMA profile was comparable in the groups, and post WLST accompanied gastric dysrhythmia was also comparable in both the groups. But post WLST duodenal hyperactivity was observed in 1/4 of gastroparesis patients, which was not observed in functional dyspepsia patients. Power distribution, both in the fasting state and in the fasting state and post water load satiety test, was comparable in all the groups. Then we segregated the patients into two types. First was based on gastric motility, which was delayed or normal based on gastric emptying scintigraphy, and second on ICC functionality. That is, it was if it was 3 CPM normal or hypernormal, then it was functional ICC, interstitial cells of Cajal, and if it was 3 CPM hyponormal, then it was non-functional. We determined power distribution and power change for both the groups. Power change was obtained by subtracting preprandial power distribution from average of postprandial values. A positive power change for normogastria indicated gastric contraction, while a negative power change suggested slow or absent contraction. We assume that positive power change for dysrhythmic frequencies indicates slow or absent contraction and vice versa. And interpretation of this is, like, if the gastric motility was delayed and ICCs were dysfunctional, then symptom severity was due to dysrhythmia, and this was the most severe case. If gastric motility was delayed but the ICCs were functional, then symptoms may be attributed due to functional or fixed obstruction at antrum and pylorus. This was severe, not more severe, but severe. If gastric motility was normal but ICCs were dysfunctional, then there may be role of ICC dysfunction for symptoms, and this was also severe. This can also be said to be severe. And if gastric motility is normal and ICCs are functional, then there may be extra gastric causes for symptoms, and this may be less severe. So our conclusion is that water load satiety test based EGG can distinguish between normal and dysrhythmic GMA, imperative for understanding pathophysiological phenotypes of gastroparesis and functional dyspepsia patients. If coupled with nuclear scintigraphic studies, it may provide superior insight for distinguishing severity, and analyzing extent of power change in normogastric and dysrhythmic frequencies may comprehensively tell about disease severity. So that was my work.
Doctor, in your study, what were the symptoms in the patients who had functional dyspepsia?
Postprandial, early satiety, postprandial fullness.
So how do you compare this with the gastroparesis? Were the symptoms comparable or?
Comparable in both gastroparesis and functional dyspepsia. Both suffered from predominant postprandial distress syndrome.
Do you think this is appropriate for a clinical setting, that we should do this investigation for management of our patients?
I didn't get your question.
So is this procedure important in terms of managing a patient?
Yes. If done together with nuclear scintigraphic studies, then it can tell about the phenotypes, like the cause of their distress, whether it is dysfunctional ICC, and if it is dysfunctional ICC, if there is obstruction at the pylorus, and if the if it is functional ICCs, then the pylorus is functioning fine. There may be extra gastric causes for it.
Dr. Mustafa, do you think functional dyspepsia is ensuing because of gastric dysmotility?
Functional dyspepsia
Is it a part of the gastroparesis? Because, as the severity of the gastroparesis increases,
yes, there is overlapping symptoms and they are part of same spectrum.
is it not continuing of the illness? Then why do you want to have separate phenotypes?
Like that will help in treatment. Like if pyloric dilatation has to be given, if there is extra gastric causes, then the treatment will be different. No pyloric dilatation.
Would you like to do pyloric dilatation on these parameters alone?
That clinicians will be able to answer.
So one more time, this functional dyspepsia and gastroparesis, there is a lot of overlap of the symptoms.
Overlap of symptoms, yes.
But based on the objective testing, can you differentiate? Can you tell these two entities are apart?
In our center, the gastroparesis patients were more severe. They had weight loss, unintended weight loss. They were not, their gastric accommodation was less. They consumed less amount of water, and they exhibited symptoms like vomiting, reflux more than the functional dyspepsia patients.
And these are idiopathic gastroparetics or diabetic, or what kind of gastroparetics?
Diabetes was predominant in gastroparesis patients, but they were idiopathic also.
And is there any difference between idiopathic versus diabetic gastroparesis?
No.
Thank you.
Like there is no change on the phenotype. Like if it is diabetic or idiopathic, EGG cannot differentiate it.
But do we have adequate numbers to make the statistical difference? So you have, what, 30 or 40 patients?
40 in gastroparesis and 39 in functional dyspepsia.
So based on the variability in the data, can you say statistically that these two groups are different or the same?
They are part of same spectrum. They are part of same spectrum.
Thank you. The next presentation is by Dr. Gauri Nayak on the topic comparison of clinical and high resolution manometry findings in a patient of ineffective esophageal motility as per Chicago classification versions 3 and 4. Is Chicago 4 classification too stringent?
Not present, as you should there.
A very good morning to respected dignitaries and my respected audience. I am Gauri Nayak from Nair Hospital in Mumbai, and this is my study. Comparison of clinical and high-resolution manometry findings as per Chicago classification versions 3 versus 4 in patients of ineffective esophageal motility or IEM. IEM is considered the most common esophageal motility disorder diagnosed on HRM with a relatively undetermined clinical significance. It has varied clinical presentations like dysphagia, GERD, and its prevalence ranges from 14 to 30% in various studies in symptomatic individuals or even higher, and up to 17% in asymptomatic individuals. Whether it is caused by the differential innervation of the striated versus the smooth muscle, or disorders of secondary peristalsis, or the presence of dilated intercellular spaces is not clear. As the definition of IEM has evolved, the Chicago classifications are evolving. In the Chicago classification 3, they were grouped under minor disorders of peristalsis, requiring more than 50% ineffective swallows for diagnosis. Now, ineffective swallows are those with DCI of less than 450, whereas weak between 100 to 450 and failed less than 100. Now, Chicago classification 4 went a step more stringent. They removed the minor major categories and grouped them generally under disorders of peristalsis, requiring 70 or more ineffective swallows and 50 or more failed swallows. So Chicago 3 requires 50, 4 requires 70, then what about this gap? So this gap they have termed to have inconclusive diagnosis. Supportive testing will strengthen confidence is what they have said. They require evidence of poor bolus transit on impedance or barium esophagogram or lack of contraction reserve on MRS. So we wanted to see what happens to these declassified patients, how are they different, how stringent is this new classification, and what is the prevalence of failed versus weak contractions. The research hypothesis being Is there or is there no difference between clinical, endoscopic, and HRM parameters in patients with IEM defined as per Chicago classifications 3 versus 4? So, in this retrospective study, we took all consecutive patients who, from September 20 to April 24 who satisfied the criteria of IEM as per Chicago classification 3. Then we counted their ineffective, weak, and failed swallows, and based on this, we divided them into two groups. Group 1, patients still qualifying as IEM as per Chicago classification 4, and group 2, who no longer classified as IEM under 4th classification, that is the patients who got declassified. Then their demographic, clinical, and HRM findings were compared. Out of total 719 tracings, 101 patients had IEM, and out of them, 80 retained their diagnosis under Chicago 4, whereas 21 got declassified. Comparison of clinical parameters, the mean age was 46 in Chicago 4 group, 41 years in Chicago and the declassified group with a female predominance, but there was no significant difference between dysphagia, regurgitation, chest pain, or weight loss as the presenting symptoms. Even in the endoscopic findings of hiatus hernia, esophagitis, antral gastritis, there was no clinical difference. Comparison of HRM parameters, the mean LES pressure, presence or absence of hypotensive LES, mean IRP were similar, but the mean DCI was significantly lower in the Chicago 4 retained group. Another important finding, in the patients who were declassified, majority had weak swallows. That is almost 95% had weak swallows, whereas only one patient had failed swallows in the declassified group. So the prevalence of failed swallows was significantly higher in the Chicago 4 retained group. Also, many studies have shown that the esophageal reserve is poorer in patients with Chicago 4, but our study didn't match this finding. Reviewing the literature, the 7 studies here showed that the percentage of patients getting declassified, maximum prevalence was 40, minimum was 25, but our study had 21. In the study by Curin et al., 37.9% got declassified, no difference between demographic or endoscopic findings, but the mean DCI was significantly lower in Chicago 4 group, peristaltic reserve was poorer, and acid exposure time was elevated. Another study by Tuan et al. Showed that prevalence of failed contractions was significantly higher in the Chicago 4 group as compared to the patients who got declassified. Also, they said that the esophageal function is more worse as indicated by incomplete bolus transit. And another study by Jain et al., they showed that failed swallows are functionally more relevant than weak swallows in the treatment of patients with ineffective esophageal motility. Hence, the take-home message is no differences between retainers of IEM as per Chicago 4 and those who got declassified in clinical presentation and endoscopic findings. Chicago 4 group had a lower mean DCI and more failed contractions. Because when we began analyzing, we felt that why have these patients been declassified if everything is similar? But then we realized that failed contractions are way more in Chicago 4. Declassified group had more weak than failed contractions. The esophageal reserve was not significantly different between the two groups. IEM should be diagnosed with more emphasis on the failed swallows. Further studies should be directed to find out the threshold of only failed swallows for diagnosing IEM in Indian patients, which we plan to do next. This study being retrospective, a relatively smaller sample size, referral bias, and the fact that impedance and pH metry studies could not be done are our limitations. Thank you.
Dr. Nayak, excellent presentation. My question is, this is what Chicago 4 has done. Rather than having a large heterogeneous group of failed versus weak peristalsis, they have tried to subgroup of the patient who really need some help and can be classified. So what is the novelty? You have similar studies showing the same result. What is new in your study? Name one parameter.
So first, we were not ready to accept the Chicago classification as it is for our population because we felt that the declassified patients initially had all similar characteristics. Then don't they require treatment? Because as the clinical symptoms are similar, the endoscopic findings are similar. To make a clinical diagnosis, we cannot differentiate them.
But why do you need to differentiate? When for weak versus failed peristalsis, there is hardly any change you can make. So why don't you want to accept Chicago 4?
Sir, when the diagnosis comes on the manometry result, then to tell the patient or the patients who will come on follow-up that you no longer have IEM. So how to deal with that?
See, look at this. Your presentation was very good, but my worry is it not a circular argument theory? See, the Chicago 4 says more than 70% has to be ineffective. Chicago 3 says more than 50% is enough. Now, you now say DCI was lower in Chicago 4 retained group versus Chicago declassified group. By definition, this has to happen. Only thing is, I want to know what happened to this patient. If I look at the follow-up of them, if I look at esophageal emptying them in them by any means. So I'm trying to say, are this declassified group having some significant issue? Then they are more like normal. That is what my question is.
So out of the 21 patients who got declassified, we have had repeat manometry of only 3 to 4, and they still are in the IEM classification as per Chicago 3, not as per 4, sir. That is the DCI.
No, do you have any data on esophageal emptying using time barium esophagogram, or maybe emptying by impedance if you have done impedance manometry? This is what I am interested in.
So that's our limitation. We couldn't do impedance.
So this was beautiful presentation and it's an important topic. So you get high scores for that. The question I have is more philosophical. So these classifications are based on consensus documents. Ideal classifications should be based on either pathophysiologic basis or outcome. So I think I think the important thing is, are there different outcomes based on these Chicago 3 and 4? Should we treat them differently? What's your opinion on that?
Right, sir. Because once we give the diagnosis, the patient expects treatment. Also, many a times, some of them may not warrant treatment if their symptoms are just corrected with a PPI. But many of them will keep coming back, and then we have no answer because to declassify you from IEM group or to keep treating.
Majority are asymptomatic, no?
Ma'am?
Majority of these patients with ineffective peristalsis are also asymptomatic.
Ma'am, again, because we did HRM of only those who came with symptoms, but as per data, majority are asymptomatic.
Thank you. Thank you.
Thank you.
Thank you. The next presentation is by Dr. Prajna Anirvan, and the topic being real-world application of Shank Prakshalana, a yogic technique in bowel preparation for colonoscopy in a busy outpatient clinic, a validation study.
A very good morning to all the faculty, dignitaries, and the audience present here. Dr. Prashna won't be available at the moment because of flight delays. Myself, Dr. Ankit Tandon, a DM resident at DMC Ludhiana, will be presenting on his behalf. So achieving an optimal bowel preparation is pivotal for a successful colonoscopy. Also, we know that bowel preparation is indicated for elective colorectal surgeries and also prior to double contrast barium enema studies. But in private clinics setups, ensuring adequate bowel preparation can be challenging due to several factors, like patients might be traveling from far-flung places, there might be non-availability of inpatient accommodation, cost factors are there, and also patient might be non-compliant. So, an ideal bowel preparation regimen is defined as the one which can empty the colon in a rapid fashion with no gross or histological alteration of the colonic mucosa. It should not cause any patient discomfort or shift in fluid or electrolytes, and it should be safe, convenient, tolerable, and inexpensive. But from our experience, we know that none of the available bowel preparation regimens are actually ideal. In this context, a recent study was done at AIIMS Bhubaneswar in a tertiary care in AIIMS Bhubaneswar, which sheds light on Shank Prashalan, which is a yogic technique, which is a promising solution for the same. 230 patients were enrolled which underwent Shank Prashalan. The mean Boston bowel preparation scale was 8, and bowel preparation was inadequate in only 2 patients. So these novel findings underscore the efficacy and safety of Shankar in achieving optimal bowel preparation before colonoscopy. Now, in the current study, the rationale is that the above study conducted in a tertiary medical center with ample scope for translational research, because a large bulk of colonoscopies are performed in private clinics, it is imperative that the practicality of Shankar should be evaluated in such a settings. And the aim was to evaluate the feasibility and effectiveness in the bursting environment or a real-world outpatient clinic. So it was a prospective study done at Kalinga Gastroenterology Foundation. Study period was between March 24 to April 24. Patients requiring colonoscopy underwent bowel preparation by Shankar using the methodology which I will be describing. Though excluded were those with poor performance status, those diagnosed with bowel stricture, those with any history of major abdominal surgery, and those who were unable to perform the asana. So bowel preparation was assessed using Boston Bowel Preparation Scale. So this is what was done. It is actually Shankar includes 5 asanas. The first is the Tarasana, which includes stretching arm in the standing position. Second is the Tiryak Tarasana, which includes arm and side body stretch in standing position. Third one is the Katikasana, which includes twisting stretch in standing position. Fourth one is the Tiryak Bhujasan, which includes upward facing position followed by twisting of the body to either side. And the fifth one is the Udar Krishasan, which includes tip toss position with twisting stretch on either side. So each asana is performed 8 times. And this will constitute 1 cycle of the Shankar and 6 cycles need to be done. So each cycle is started by drinking 400 ml of warm saline water. So this is prepared using, we put 2 tablespoons of salt in 1 liter of water. It was performed on 30 patients with the mean age of 45.6 years, and the Boston Bowel Preparation Scale was mean was 8.6. The segmental Boston Bowel Preparation Scale was 2.9, 2.9, 2.8 for the right, transverse, and left corner respectively. The adequacy of bowel preparation was 100%. It was seen in all the patients. Time to complete bowel preparation of 140 minutes. Number of motions on mean number of motions was 6. Amount of fluid consumed was 1700 ml. Cecal intubation time 8.8. And the pain during colonoscopy on a visual analog scale, as noted by the patient, was 3. Adverse events, there was nil. So Shankar additional advantage that it was performed on the same day of colonoscopy, which minimizes the disadvantage associated with split door preparations or even a single day preparation, which have to be taken 1 day prior to the procedure. Adequacy of bowel preparation achieved 100%, like I said. Number of motion pass was 6, which is quite efficient, and the amount of fluid consumed is also less than 1800 ml, which is when compared to the conventional methods using PEG. Time taken bowel preparation is 140 minutes. This is also less when compared to the conventional PEG-based preparations. Boston Bowel Preparation Scale of 8.6 is comparable to PEG preparations and maybe even better, because the studies using PEL report this to be between somewhere, different studies report between 7 to 8. And the median visual analog scale for pain was 3, which is much less if we compare with the historical cohorts, usually in which the pain was reported to be of the frequency of up to 73%. So to conclude, the take-home message is that Shankar, if practiced in clinic, can be safely performed for bowel preparation before colonoscopy in an outpatient clinic with good efficiency and patient acceptability. Thank you.
You see, it is presumed that most of these patients were fit and robust and healthy enough to undergo this type of yoga. Is that the type of patient you call for colonoscopy? Most of these patients are suspected of IBD, GI bleeding, weight loss. Do you think in any case you are giving about, if you see 5 sessions, each consuming around about 400 ml of water, 2 liter, in any case you are giving. So why not a well-established peg-leg preparation, which is equally good? You see, you expect these people to have multiple turns, twists, and somersaults in a sick condition.
Sir, Pegleg preparation is usually started a day prior to the procedure, so it can also lead to sleep disturbances are there. Additionally, it can lead to, it has complications like nausea, vomiting, bloating. So these are, as we see, there are no adverse effects among these patients, first of all. Additionally, this can be started on the same day. Like we can call the patient at 8 a.m. and 9 a.m. in the morning and do his colonoscopy on the same day after maybe 2-3 hours.
How do you think this yoga increases the movement of selectively the right colon, then transverse colon,
So,
over and above the other parts of the body?
like I said, there are 5 steps involved. So, the first step, which is Tadasana, that when compared to the scientific, the physiology, gastric physiology, so the first step will be opening the pylorus. The second and the third step, which is the Riyak Tadasana and the Katish Kadasana, that will be leading to the contractions of the small intestine. The fourth step, which is the Tiryak Bhujasana, that will be leading to opening of the ileocecal valve. And the last step, which is Udara Krishnasana, that will be causing alternate contraction, relaxation of the large intestine.
What will be the frequency in between? No, the patient starts taking the saline. The patients, they take the preparation and then they start the yoga. When does this start, the bowel movement? At what time? After all the completion of the complete set, or in between and then he's not able to complete?
Ma'am, actually, it might start even after the first cycle or maybe after 2-3 cycles. But in the study, we allowed the patient to use the toilet anytime between the while performing the Shankarshalan.
You see, the study is novel, but only my issue is if we look at Panigrahi's study. His study had a large sample size. Now you have only 30 patients. So how it becomes original in the background of Panigrahi's study? That is one. Second is one of the outcome measure or result that you stated is cecal intubation rate. I would like to know ideal intubation rate, not only cecal intubation rate. And the third thing I will ask you is the competence of the colonoscopist is important when we talk about intubation. So that parameters has not been presented to us, I suppose. So these are the 3 questions that I have.
Sir, regarding the competence of the colonoscopist, first of all, if I take the original study which was done as AIMS Bhubaneswar, so in that study, first of all, the Boston Bowel Pressure Scale that was noted by the performing endoscopist. Additionally, it was rechecked by another endoscopist who has not done the procedure.
No, what I am saying is forget about that. Don't talk about Panigrahi's study. Talk about your study and say how many colonoscopies did these colonoscopists perform before. You may not answer to me now, but add this when you write a paper.
Sorry, sir.
I have a question probably along the same lines. You have 30 patients. Was there some screening criteria that you used? Because some of the patients have severe constipation or moderate constipation versus some are, regular bowel habits. So that would be important in the ultimate prep outcome. So how did you select these 30 people?
Sir, a patient having any degree of constipation enrolled, the only thing was which we took care of was that there was no comorbidities. The performance scale was good. So we actually took patient without any comorbidities for this.
I mean, the other important thing I think is the mechanism of how PEG preparations clean out the colon versus your method are totally different. PEG is not absorbed in the intestine and flushes out, but in your method, saline would be completely absorbed in the small intestine. So whatever you are doing, it is working, it's amazing and it's impressive. Maybe that could be used as a treatment for constipation, which is a huge problem, not only for colonoscopy, but as a regular treatment for constipation.
Was there a reason you didn't have a comparative group?
Sorry.
Can you turn this? Yeah.
Was there a reason you didn't have a comparative group, either patients that just had the solution, the warm saline solution and no yoga, versus peg. Ideally, I don't have a problem with the study, just the methodology. There has to be a comparative group.
Yes, sir, we have not done that for now, but for sure we are planning that with a comparison group.
Thank you.
Thank you.
Thank you. So the next presentation is by Dr. Sandeep Shah, topic being evaluation of upper esophageal sphincter matrix during swallowing on high resolution esophageal manometry.
Good morning, everyone. My paper is on evaluation of upper esophageal sphincter matrix during swallowing on high resolution esophageal manometry. So this is the swallow. When we take the bolus in the mouth, first the valopharynx will contract to prevent the retrograde movement of bolus into the nasal cavity. Then the epiglottis contract to prevent the aspiration. Tongue base and the pharyngeal muscle moves these boluses into the upper esophageal sphincter and esophagus. Upper esophageal sphincter has three muscles: inferior pharyngeal constrictor, cricopharyngeus, and upper esophageal skeletal muscle. See, these are striated muscles having very rapid and high pressure contraction, and we required the high frequency probes for evaluation. So, what's the role of US manometry, particularly in a neurological disorder where we suspect an oropharyngeal dysphagia in conditions like Parkinsonism, myopathies, motor neuron disease, brainstem strokes? And what we know by an US manometry to see the disease progression, because sometimes the US manometry findings, US matrix, precedes the development of other muscular weakness. These patients are at risk of aspiration. So certain US matrix can categorize this patient who have the high risk of aspiration. Even these are on rehabilitation or speech therapy. So if you want to see the objective evidence of a response to a therapy, this matrix will help. And this has therapeutic implications also. Like if the US sphincter is tight, you can even do the balloon Botox injection, the balloon dilatation, or even the myotomies. It can even help to identify the US structural disorders, supraesophageal reflux disease. Certain rheumatological condition have the US issues. Then post-radiation and surgery, particularly the post-laryngectomy, when you want to decide on a esophageal voice generation, this matrix will help. So US manometry is an unmet need because conventional manometry, which are water perfuse, cannot pick up the high amplitude tracing, and it has a constant water dripping, stimulates US, causing motion artifacts, and US have radial and longitudinal asymmetry, and few radial sensors may be inappropriate to evaluate the US properly. So with the high resolution manometry, it is possible, but interpretation is challenging as normal reference ranges are variable in different literature. So in our study, we have analyzed the data of upper esophageal sphincter matrix, those who underwent an esophageal manometry in our department. They were given 10 liquid swallow in supine and 5 liquid in sitting. We have used ManoVi software, and we have analyzed three parameters, that is basal US pressure, US residual pressure or relaxation pressure, which is comparable to IRP of US, pharyngeal contraction, and these are the US matrix. You can see on the topography, the upper is the mesopharyngeal complex, then the hypopharynx. You can see the US basal pressure. Then when the US pressure drops, you can see the IRP, US peak pressure, and hypopharyngeal peak pressure. So the results are total 160 patients underwent manometry in 1 year. Median age was 37 years. 53% patients were male. The most common indications was GRD, followed by the dysphagia and atypical chest pain. This is the mean and range of US matrix in our cohort. The basal pressure in a range of 54 plus or minus 35 mm of Hg. Peak pressure was 22 plus or minus 19, and US IRP 6 plus or minus 10 mm of Hg. In a subgroup analysis, gender-wise, if you compare male and female, the male patients have little higher basal US pressure than female, while other parameters like peak pressure or residual pressure are comparable in both the group. If you see the age-wise distribution of this US matrix, you can see the elderly patient has lower mean basal US pressure, and elderly patient has higher mean residual pressure, that's an IRP. So we have compared the different indication in US matrix. So the basal pressure are comparable in dysphagia, chest pain, and GRD group. If you see the peak pressure, dysphagia has group have higher peak pressure, and even the dysphagia group have higher IRP of US. So if we compare the Chicago classification wise, the US matrix, we can see that if the achalasia patients have compared with an ineffective esophageal motility, or those patients who have no Chicago abnormality was found, we have seen that achalasia patients have significant higher mean US basal pressure. Achalasia patients have higher mean peak pharyngeal pressure. They have higher mean IRP or a residual pressure. So in conclusion, range of UGA metrics in our cohort are the US basal pressure between 18 to 90 mm of Hg, hypopharyngeal peak pressure was 3 to 41 mm of Hg, US residual pressure was minus 4 to 17 mm of Hg. The IRP and hypopharyngeal pressures are comparable to previously published data, but in an Indian patient, like in our cohort, US basal pressure was lower than a normative range which is defined in a Western literature from 29 to 145 mm of Hg. In our cohort, males have slightly higher upper esophageal sphincter basal pressure. Elderly patients have low US basal pressure and high US IRP. Patients with dysphagia have higher peak pressure and higher IRP, and achalasia patients have all the three parameters on a higher side. So how do analyze the US manometry? So it is like on a sequence which we follow in a Chicago. First, we need to measure the US pressure, basal pressure, the US peak pressure, the pressure of hypopharynx and mesopharynx. Then we need to see whether there is any intrabolus pressurization. Then we need to see whether UI is relaxing, whether UI is opening, whether the flow distance is timed or mistimed. So here you can see the various topography of UES. In the first, you can see there is an high pharyngeal intrabolus pressure. So this indicates a resistance to flow. In a second, you see there is a globally weak pressure, which is quite common in myositis patient. Here you can see the pressures are on higher side. Even there is an impaired UES relaxation with high intrabolus pressure. This indicates outflow obstruction. This is seen in a structural disease affecting the upper esophageal sphincter. Then you see the lower mean UES basal pressure, which is seen in a motor neuron disease. You see the pan-pharyngeal pressurization pattern, and UES doesn't relax, which is seen in a brainstem stroke. With that, thank you for your kind attention.
Very nice presentation. So all the analysis has been done retrospectively on patients who had HRM because of the other reasons.
Yes, sir.
But you started with a premise that it is being done for neurological assessment.
No, sir. These are the retrospective data, those who have been posted for an esophageal manometry for other indications like GERD, dysphagia, and.
But they didn't include the patients who needed assessment of the UES,
yeah,
like
sir.
those with myositis, those with brainstorm,
Yes.
brainstem stroke, those with Parkinsonism.
Yes.
So wouldn't that have been better, even if you would have done 10?
Yes.
You are
sir.
retrospective analyzing the data of those who didn't need assessment of UES.
Yes. So we are just trying to understand the US matrix first. So because we don't know what is basal pressure, residual pressure, and the peak pressure. So this was the initial part of the study. We are continuing study, and now we are including the patients who are referred from a neurological department. So this will help us to compare the abnormal patients who have this.
So none of these had neurological.
No, sir. These are.
Yeah, my issue is that you are comparing the data available from the West with these data. Those are normative values in the US, and your one is not normative because these are not normal individuals. These are patients who otherwise came to you for typical esophageal problem.
Yes.
So therefore we should not compare. This is not normative data. Second issue is that I would like to know about how clinically it is helpful, because if we had some other test, for example, cine radiography or any other test, to say what these patients are as far as their US is concerned. Now then, and third is clinical implication. Somebody came for GRD and you just saw the US parameter, doesn't really help the patient. So can we characterize based on this? Maybe in future work of your you can address those issues.
Yes, sir. So these are the secondary finding, but obviously those who have a neurological disorders and all, if we know this baseline, then we can interpret those patients in a better way.
I think you should develop normative data.
Yes, sir.
Healthy controls would be ideal.
Yes, ma'am. Healthy volunteers we should
Age,
include.
age and gender
Healthy
based.
control. Yes, ma'am. Yes.
Dr. Shah, the last slide you showed us in different conditions like myositis, the different patterns of disc motility in the pharyngeal contractions.
Yes.
Is that your data or are you showing
No,
somebody
no.
else?
This is just a discussion, literature, from the literature. Yes.
So one of the things in the upper sphincter, especially with regards to the basal LES pressure, upper sphincter is a very volatile sphincter. The pressure changes dramatically from second to second. So, does that have, over the years, I have not been able to put any significance on the basal upper sphincter pressure. I put more significance on the relaxation at the IRP pressures. So, do you think it helps to know the basal upper sphincter pressure?
So US basal pressure can be affected by various parameters. Like if we have done immediate after insertion, they will be abnormal. If the patient is on stress with some psychological issues, they have even abnormal. So even in the 10 reading, we can see variation. So we can always define a range. So obviously the time will tell how we can proceed in an interpretation. But these are just our data, what is the normal we see in our patients. Thank you.
Thank you. So the next and the last presentation of the session is by Dr. Venkatesh V.S. The topic is fructose malabsorption in patients with functional abdominal pain syndrome, frequency and predictors.
Thank you, INMA, for providing this opportunity to publish our data on fructose malabsorption in patients with functional abdominal pain syndrome, frequency and predictors. Introduction. Functional abdominal pain syndrome is a state of chronic recurrent abdominal pain that is not due to structural, organic or metabolic cause. The precise etiology and pathophysiology of functional abdominal pain syndrome is poorly understood. Brain-gut interaction plays a crucial role in as in most of the pain-related functional GI disorder. Rome 3 diagnoses this functional abdominal pain syndrome as continuous or near continuous abdominal pain, no or occasional relationship of pain with functional events such as eating, defecations, some loss of daily activity, and the patient is not malingering, and it has insufficient symptoms to meet the criteria for other functional GI disorder that would explain the pain. Whereas in Rome 4 criteria, functional abdominal pain syndrome for adult has been replaced with centrally mediated abdominal pain syndrome. Coming to fructose. Fructose is a 6-carbon monosaccharide which can occur in 3 forms: pure monosaccharide, disaccharide the sucrose, or polymerized to form as oligosaccharide or polysaccharide. In human body, fructose is absorbed only as monosaccharide. Fructose malabsorption can cause osmotic load to the small intestine, which leads to abdominal distension, pain, or it can cause increase in colonic motility. It can also act as a prebiotic which increases the gut microbiota. In a systematic review, it has been found that across all functional GI disorders, the intolerance of the fructose is seen in 60%, whereas small absorption is seen in 45%. In a study by Dr. U.C. Ghoshal on fructose malabsorption in a patient with irritable bowel syndrome, which is a case-controlled study, the prevalence of fructose malabsorption on irritable bowel syndrome was 14.4%, whereas in healthy controls is 2.4%. Among their study, diarrhea-predominant IBS had more fructose malabsorption when compared to the others. Whereas the role of fructose malabsorption as a cause of functional abdominal pain syndrome is not adequately evaluated. Whereas we have various studies of on fructose malabsorption, predominantly involving children with chronic abdominal pain or recurrent abdominal pain. They use various cutoffs of fructose dose, and few studies have excluded SIBO. And the prevalence of fructose malabsorption ranges from 17.6% to 65%. So the lacuna is there is no published case control study exclusively in adults in patients with functional abdominal pain syndrome evaluating the prevalence of fructose malabsorption. There is positive data along prevalence of fructose malabsorption in patients with functional abdominal pain syndrome. So our study was done to study the frequency of fructose malabsorption in patients with functional abdominal pain syndrome, the occurrence of resultant symptoms in patients with positive results with fructose breath test. Our study was case control study. The study duration was 2 years. Sample size was calculated accordingly based on previous studies with fructose small absorption in other functional GI disorders. We calculated the sample size of cases of 40 and controls of 20. We included 68 patients and 31 healthy controls. Patients aged 12 to 16 years seen in gastroenterology OPD who presented features fulfilling criteria of functional abdominal pain syndrome as per Rome 3 were included. Healthy persons was included as control. Patients with known suspected hereditary factor intolerance, other standard exclusion criteria was applied. So all patients underwent clinical history, examination, glucose hydrogen breath test for SIBO and functional fructose hydrogen breath test. Other only cases underwent complete hemogram, renal and liver function test, routine microscopy and celiac serology. So in the study protocol, we screened the patients. Patients satisfying Rome 3 criteria for functional abdominal pain syndrome were included. We did first GHBT and we excluded 7 patients who are positive for SIBO, and FHBT was done for 61 patients, whereas in healthy control, no patients had SIBO. This is important because small bowel intestinal obstruction and functional malabsorption, fructose malabsorption has bidirectional relationship as in this figure. Because fructose as malabsorption acts as a fast food which increases the SIBO, whereas SIBO act as a SIBO act as a competition of luminal fructose which decreases the fructose absorption. So GHPT was evaluated routinely. We used persistent breath hydrogen test more than 12 parts per million as a considered diagnostic for SIBO and 20 parts per million considered diagnostic for fructose malabsorption. Any patients who is developing symptoms during FHBT was recorded on Likert score. The symptoms included are nausea, vomiting, bloating, flatulence, abdominal pain, abdominal distension or diarrhea. Standard statistical analysis was used. Coming to the results, baseline characteristics of cases and controls are comparable. When we see the fructose malabsorption, the prevalence of fructose malabsorption on patients with functional abdominal bowel syndrome was 26%, whereas in healthy controls are only 3%, which is statistically significant. When we compare these relationships of the symptoms during fructose malabsorption among the all participants, the symptoms are more prevalent among cases, which is around 40% when compared to the healthy control, which is around 12%. When we compare the symptoms arising during FHBT among cases alone, patients who has no malabsorption, that is FHBT negative, had symptoms of 31%, whereas patient who had malabsorption, that is FHBT positive, had intolerant symptoms of 62%, which is also statistically significant. Then we did univariate analysis to find the predictors of FHBT positive among cases, where we found younger age, male gender, and low BMI and high vegetarian diet are all the predictors of functional FHBT positivity. Whereas in univariate analysis, only age and male gender were statistically significant. So the strength of the study is, this is the first study to evaluate the pathophysiology of functional abdominal bowel syndrome with respect to the role of fructose malabsorption. And this is the first study in the world to evaluate the fructose malabsorption in patients with functional abdominal bowel syndrome predominantly involving adult population. All other previous studies were children's. We excluded SIBO by using glucose hydrogen breath test for ruling out the false positivity of functional abdominal FHBT positivity. Limitations being, this is a single center study, sample size was adequate but not large. We gave non-physiological diet, whereas only fructose was given. We all know that glucose is also known to modulate the absorption of fructose based on GLUT receptors. And the time duration we used only for 3 hours, whereas 5-hour duration increases the sensitivity of fructose malabsorption. We didn't have the follow-up of patients with dietary intervention and symptoms evaluation. So conclude, around 1/4 of the patients with functional abdominal bowel syndrome has fructose malabsorption. Majority of the patients had symptoms suggestive of functional intolerance. Younger age, male gender were found to be independent predictor. Further studies are needed to define the role of FODMAP or dietary intervention in management of functional abdominal pain syndrome.
Nice presentation. Don't you think the functional abdominal syndrome, it is a mixed bag of so many entities? Functional dyspepsia, irritable bowel syndrome, anxiety. And did you try to look at the composition of the diet? Whether they had more fructose consumption than the general population? And finally, why should there be a selective malabsorption of fructose in a patient destined to have malabsorption over and above the other constituents of the food, like glucose, like protein, like fat? Are there any specific pathophysiological mechanisms? You have a selective malabsorption of fructose?
No, sir. It is together, but we
Or is it
predominantly.
that the sheer volume of the fructose is so much that only part of it can be absorbed? I think your dietary composition could have given you better results.
Yes, sir. That is missing in the study.
Is there a reason you included children up down to 12 years of age and not predominantly adults? Is there a reason you included younger population in your group?
No, sir. We took adult group only. The predominantly age group, we took 12 to 60 age, 12 to 60 age of group, but predominantly are more than 16 to 17 age group people. We wanted to include adult patients, sir. The fund of the study is wanted to include adult patients.
So about how many of these of your population was less than 16, was less than 18 years?
Sir, I couldn't hear you.
How many of your patients in your cohort were less than 16 or less than 18?
Sir, around 31, 61%, around 10%, 5 to 6 patients are less than 15.
And what's the definition of a positive fructose test? How much hydrogen has to go up?
Sir, more than 20 parts per million.
More
At least
than-
2 well.
How much?
20. We have taken
So
20.
which is different than the glucose. For the glucose, we need 12 or 13,
Yes,
right?
sir. Yes. Thank you.